watch. Okay, we don't want them to watch. We don't want them to get in the way of our testing by either bracing the joint, guarding, things like that. Okay, so it's for anterior joint one our patient in this position right here. Okay, as best they can. So when we're looking at initial injury for ACL, they might not be able to get to this point. Show of hands, who's torn their ACL? Okay, when they did the initial test, could you get that far? It was more so maybe kind of like right in here. Why couldn't she get further up? Why? Swelling gets in the way. So if we don't do this test within the first 5 minutes, chances of us getting a good result go way down. Because not only swelling increases in there, but then the joint tightens up, and it's the body's way of protecting, so the body splints itself. So the body will splint against that movement. It doesn't want to get hurt anymore, so it does that on purpose. So if we do this within the first 5, we should be pretty good. Okay? You have a couple landmarks that I want you to focus on when dealing with the anterior drawer. Seal tuberosity. Okay, big landmark right there when it comes to positioning of hands. Hamstring tendons in the back. Okay? That's how I cut the hamstrings off, preferably. When it comes to this test, I actually put my hands and I pull up on those, and so I cut them off. Just like when we do our other tests, when we flex and extend the hips and stuff like that for looking at, or like bend the knee when we're looking at gastroc and soleus stuff. If I inhibit through the hamstring tendons by pushing on those tendons, the hamstring doesn't fire as much. And if it does fire, I can feel it. So then I can talk about that a little bit more. Positioning of the foot, straight ahead. Okay, there is another test where we have some rotation in the foot, but right now we want straight ahead. Okay, positioning of my hands. My thumbs, fingers that go back here on the hamstring tendons. Thumbs go right. So if I go to tibial tuberosity, I go straight up, and I find those little divots right there. Okay, those little divots represent the top of the tibia and give me a place to put my thumbs. My fingers are like this underneath, and my thumbs are like this. Okay, I've hooked onto the tibia right through here. Okay, and so multiple ways to do this. Some will just get on there and we'll just jerk it. Okay, Dr. Lynch is one that will go slowly to begin with and then jerk it. Okay, but we want to have some sort of rapid pull towards ourselves. We don't want to go nice and slow all the way through, just because, like we've said before, injuries don't happen that way. We need to try and mimic the mechanism of injury. So I will sit on the foot. Why am I sitting on the foot? If I do this without sitting on the foot, I'm going to kick myself in the face. Because I pull his leg this way, this is going to come up and I'll kick myself. So sit on the foot. Okay, keeps from sliding forward, keeps from coming up. Lock underneath here, find my little spot on my thumbs, put it right through here, and then I pull, and your patient will move. Okay, if you do this, that's not anything. Okay, your patient needs to move. Okay, I'm here and I use my body weight and I just pull. Okay, by locking his hamstrings right through here, I'm now grabbing all of this and I'm holding those in and they can't fire back. They're fairly loose with me pulling on them. So that's anterior drawer. Thumbs in this little spot, fingers up underneath, pull. Okay. Since we're in this position right now, posterior drawer, same thing. I'm here already. I pull this way for anterior, posterior drawer. I use the palms of my hands and I push. Okay. If I push and this goes down, then it's indicative of PCL. ACL, when I do this and I pull and that opens up this way, it's a definite feel. You can feel it. The first time you do it, it might freak you out a little bit. You might do this. You're like, okay, I'm going to do that again. That's kind of cool. That's what happens. You will see the knee open up. Okay, you are pulling the tibia away from the femur. Pulling it away and pushing it away. Okay, that's anterior and posterior drawer. Lockman's test. Same thing when looking at ACL, but it's a different mechanism. Okay? I'm trying to, again, establish ACL integrity, so I want to be able to pull the tibia away from the femur. So traditional hand position placement is one above. He's got big legs. This is hard for me. I don't have big hands. Okay? So I have to grab up here, hold this, and I have to grab down here and hold this. And so what I'm trying to do is take his leg. One hand, I push down with this one, and I pull away with this one. Okay? It's almost, I'm not necessarily doing this, but I'm stabilizing this part of it. I'm stabilizing the femur and pulling away. Okay? With Dean, his hamstrings are they're huge, right? I can't grab a hold of it very well. This isn't a great option for me with him. Okay, but there's another way we can show it. Okay, so that's traditional. One of my docs showed me a great way to help with this. Okay, in this position right here. Okay, is he in a relaxed position? Foot straight ahead. Is that relaxed? Look at that foot. What's that one doing? Externally rotated. If we externally rotate the hip, that relaxes all the muscles through here and opens up the hip. And now it takes everything, potentially that could cause some guarding, and it takes it out of play. Okay? For him to contract his hamstrings, he's going to have to take his leg and move it all the way this way. I'm holding it, not going to happen. Okay? Plus, in this position, the joint goes from a closed pack to an open pack. It opens up. The joint opens up wide, and I can now have better movement with that. Hand position is the same. Here and here. My line of pull changes, though. In this way, I was pulling straight up with this. I was going this way. This way, I'm pulling out, like toward my armpit. Okay, I'm just going this direction with it. This one is hard for me to do. Again, I don't use this one very often. Because one, I don't have big enough hands, and two, due to some just old baseball stuff, it hurts my thumbs. I jam my thumbs so many times, me putting pressure on my thumbs hurts. So I don't do those very often, okay? But in terms of positioning, here and here, I will stabilize the femur, and then I will pull this direction, okay? A modified version of that, just move back this way or something, because I have to get right where you are, is taking it, and I'm gonna bend his knee. I'm going to put mine underneath it. Okay? By doing this, I have now taken the, instead of having to lift it, hold it myself, my leg's doing the work. So now I can brace here, grab here, and do it that way. You can use your leg, you can use a foam roll. Those foam rolls are a little big, so it might not work as well. It gets you more than 25. Okay? But again, putting my knee underneath it makes this an open pack position. Joints open. If I externally rotate them a little bit more, now it's really open. I don't have to grab here anymore. I can just stabilize onto my leg, use this hand, grab here, and then again, change the line of pull towards me this way. Okay? That's the modified version. Okay? Flip over on your stomach for me. The prone version, you have to scoot to the edge of the table. Keep going, keep going, keep going. All the way to the edge, right there. Prone version. Come on, relax.
Relax.
There you go. I can grab that and relax. How's that relaxed? There you go. Okay, in this test right here, I won't do this one on you, just because I won't. But you relax, seriously. I got it right here, man. Okay. Come on, play with me, guys. Let's go. Prone Lockmans. I hold here, and all I'm going to do is put my other hand right here at the base of the knee, right on the gastroc. And I'm just going to push. Okay? It's the same thing. It's the same thing as pulling. I'm pushing that way. I provide stabilization here and push out this way. What would I see if I push here? Would that open up this way? It should. Okay, as long as he's relaxed. Okay, but this is, if you can't do the Lockmans in either the regular way or the modified way, this is another way that you could do this. Okay? Not something that I would recommend very often because it is hard to get somebody to relax over here. Why is it so hard for you to relax right now? One, because he's hanging off the edge of the table. And that's a rough position to be in right there. This is natural. Okay? Even though I'm holding his leg here, it's hard for him to relax because he's hanging off the edge of the table, and so he wants to naturally support himself. So it's hard to do. Okay? But it's something that you can do. Okay? So that's your prone Lockman's test. Again, stabilize up here by the ankle, just support up here, knee hanging off the edge of the table, and you're just going to push. Push, base of my hands going that way. Pushing down. Okay, not down, I'm just pushing in the direction of the joint. Okay, does that one make sense? Okay, go ahead and flip back over. The last test is Godfrey's test, it's PCL, and we're using gravity. You can have your patient lie on the floor, you can have them lie on a table. Generally when I do this, I'll have them lie on the floor and I'll put a chair underneath their heels. Okay, but we want our patient bend in a 90-90 position. Okay, 90 at the hip, 90 at the knees. And then I put a chair underneath this point of it, and then I walk away. Come back 3 or 4 minutes later, and if I see any sagging of the tibia, say this one's the hurt one, and it's dropped down as compared to this one, it's a positive test for PCL on that side. I don't do anything. Gravity just pulls it down. But I've got to have something underneath here. I don't want to sit here for 3 minutes like this. Okay, 3 to 5, I don't want to do that. So put something underneath it. Okay, and it gets them to relax, and then all of a sudden if that relaxes, then you'll see this drop. So you're going to compare this side to this side. So you're going to get down low, look at them both, and see which is which. Okay, if one of them is lower, indicates most likely that there's a PCL issue. Okay, here's a funny little situation. Go to layback. This doc likes to do this test. It's a weird ACL test. It does make sense. Okay, but I'm not sure how definitive it is. He will take his fist and put it underneath here. Okay? Now, if I take this and I'm right underneath his knee right here, and if I push down on his quad, I should get some sort of reaction if it's connected. Because if I push down here and I'm here, his foot should elevate up. If I am here like this and I push down and I get nothing, then there's no connection right through there. It is another version of a test. He does it in the surgical room, in the operating room. I've never seen it done clinically, but it's something that I saw during a surgery. It was one of these little weird tests that he came up with. And here start pushing around stuff, and if the foot bounces up and down, then it's connected. If it's not, then then the ACL is torn. So it just kind of depends. But if you have a chance to see an ACL surgery, very, very violent in the operating room. Okay? So those of you that had ACLs, I apologize to share this with you, but this is what happened when you were sleeping. They took your knee and fixed everything, and then they basically tried to rip it again. Any possible direction they could get it to go. Okay, they're cranking on that thing.